and welcome to another edition of the Toronto General and Western Hospital Foundation Virtual Q&A. I'm Christian Cote, host of UHN's Behind the Breakthrough podcast. We're glad you could join us, and we're grateful to you, our community of supporters who've been so generous during this time of the COVID-19 pandemic. Thank you on behalf of the foundation and all of us at UHN. Today, we want to look into the future. Now that we're flattening the curve, everyone's very eager to find out what's next. What will life look like now as the province begins to reopen over the next weeks and months? To help us with this topic, we are joined today with their insights of Dr. Alon Vaisman, an infection control physician at UHN. Welcome, Dr. Vaisman.
Thank you for having us.
And Dr. Beate Sander, Director of Population Health Economics Research at the Toronto General Hospital Research Institute. Welcome, Dr. Sander.
Thanks for having me too.
As you can see, the three of us are in different locations. We're continuing to practice physical distancing. And for this episode, you'll notice a few format changes. We recognize that as questions come in, a number of them fit into a particular theme or themes. So we've grouped them that way. Hopefully that avoids repetition and we can get to more of your questions. We're also going to devote the first portion of our time today to some top of mind questions, leaping off from this week's headlines. Especially as we're talking about reopening this week, one of the biggest issues that we were wondering about is, and Alon, I think I'll put this to you, is this whole issue of sheltering at home. Is it still a health priority to be doing this now that we're flattening the curve?
Yes, it's an excellent question. When we say shelter at home, it may sound like we're trying to say to hide from the public, but it really means it's just trying to minimize your exposure to the outside world. So just as it was important the last 8 weeks or so to do this, it's going to continue to be important in the future. As the government starts to open up things and make things more available to the public, it'll still be important to maintain that principles as best as we can. Try not to go outside if it's not necessary to do so.
Okay, so on the flip side, what are we to make of the new mantra this week of go outside, but do not congregate? Like, what does that mean?
Yeah, so what it means is basically you can go outside if you need to go outside, if you need to maintain your mental, physical health by running, by walking, by going picking up food. It's just that you should try to avoid making close contact with your neighbors, making close contact with other people. So trying to still maintain the social distancing at least 6 feet apart from each other as best as you can, no matter what it is you're doing outside your home.
What should we be wearing? I mean, I know we're not gearing up with PPE like they do in hospitals, but what should we be wearing?
Based on the recommendations from the Canadian Medical Officer of Health, there is some recommendation around wearing a mask for some individuals when they leave the home. It's unclear whether we should be masking the entire population every time we leave our houses. However, it's understandable that some people, when they leave their home, will feel more comfortable wearing a mask. For example, a fabric mask that they might have bought or they made from home. So that's reasonable to do for some individuals, I think. Some people also choose to wear surgical masks and other heavier kind of masks like N95s. That may not be so necessary, but it's important to just not only wear the mask that was recommended by the Canadian medical officer, but also the social distancing. I think that's the part where people sometimes aren't as aware and aren't keeping track of as best as they can.
Dr. Sander, I want to come to you because I read, as part of our preparation for talking with you today, a quote that you gave with the Globe and Mail recently where you said, closing everything down was probably easy compared to what we have to do now. Can you walk us through what you mean by that?
What do I mean by that? Well, I thought, the situation was really quite terrible early March. And so to make that decision to close everything down was relatively easy because I think everyone was kind of on board with that. And we have to do something to avoid being Italy or to avoid being what turned out, what we saw in New York and around the world in other cities. But so now where the case numbers go down, the ICUs look okay, and people want to kind of restart what we think is normal life. And we can't just go back. We cannot just open up everything because then we're in the exact same situation we were 6, 7, 8 weeks ago, right? So then we would have maybe Italy happening, or we would have New York happening. So we have to kind of figure out what those tiny, small little steps are that we can take and be safe at the same time.
Right. I keep hearing gradual, tentative, potentially frustrating. I'm interested because of your background, which is and expertise in the whole area of modeling, and a lot of government policy is predicted based on your modeling. Do you have any insights into what sectors out in Ontario can safely reopen first, and in the cascading effect in terms of what order others will open?
Not yet. So we are working on more modeling. So that's what's also part of it's very, very complicated in the way that there's so many different options of how we could go about it. So we could think about it, specific sectors of the economy opening. We could think about schools. We think about a mix of it. We could think about small retail. There's just so many options of how we could go about it. And so to think that kind of all through and figure out what is the best way is just really, really tough. And I think there are many things that we also want to try and balance. Like we do want to balance COVID-19 cases. So we don't want to have some kind of explosion of cases. I think we are very concerned in general about all the surgeries and procedures and medical care that's being canceled or restricted. So we kind of do want to open up some of that and kind of ramp it back up. But it will also take up resources that we could potentially need for COVID-19 patients. And then we have the whole economy, and we have people stay at home and kids be at home, and concerns around mental health and poverty and all kind of other things. So trying to balance all of those is what's so challenging.
I wanted to put to both you the issue of, when we talk about reopening, a big concern for people, understandably, is going back to the workplace, or the prospect of children going back to daycare. What do you see, perhaps Alon, I'll start with you, what do you see in terms of public health measures that need to be in place for safe returns to those kinds of sectors?
I think one of the first things that needs to be done is to educate people who are going back to work, to let them know about what needs to be done at the workplace, understanding the kinds of symptoms that you might have from COVID-19, so that people are not going to work sick, and they're reporting to their occupational health departments, and also letting their team know. Because one of the ways that we can start to see problems is if people come back to work, they have symptoms, they're spreading the virus to other people in their offices and their workplaces, and that creates a problem. The second thing is to make sure that the workplaces can effectively social distance. And what that means is having workspaces that are probably going to have to be modified compared to what they were before, to make sure that staff can actually be safely spaced between each other doing their work safely. That includes lounges, includes when they're eating, includes when they're doing their work. And then a third thing is to make sure that people are aware of hand hygiene and the importance that it plays in the workplace. We think of this very commonly in healthcare settings, and frontline staff are very educated about that. But I think from now on, everyone in the population needs to understand the importance of washing your hands, keeping your hands away from your face, and having good hygiene in general.
Yeah, would you want to add anything to that?
Yeah, maybe just in terms of, I guess, going back to the modeling, like those are the type of things people think about, right? Like, so how do we bring people back to work or kids back to school and being able to keep that distancing? And so is it, the Monday, Tuesday, Wednesday people? So someone only goes on Monday and someone only goes on Tuesday. And so this is kind of part of this maintaining social distancing. No, not everyone at once and not everyone at the same time, or maybe if it's a bigger company, maybe some people work in the morning only, some only in the afternoon, and have kind of the cleaning in between. And so all those things is what's important and being considered.
It really is it's a profound change that we've yet to really unfold and experience. I'm wondering, in terms of these public health measures, are they likely to remain in place until we have a vaccine?
I can't think of how else we could possibly do it. And I mean, the other thing we haven't talked about yet is also the kind of testing, tracing, isolation piece, right? So right now, we try to prevent people from congregating and mixing and transmitting by having everyone at home. And not a public health way in terms of public health measures is to kind of figure out every single case and follow them up and see who they had contact with and isolate those people for a while. So it's challenging because you transmit already before you even know you have COVID-19. but it's another way, and it was very successful in quite a few countries. So it's a mix of all those different things. And now I keep talking, and I don't know where I started and wanted to end up, but I'm sure you will remind me, Chris.
That's okay. Well, Alon, as an infection protection control expert, what I'm curious is, do you have a sense then on the vaccine front in terms of development?
As far as I know, this is still going to be several months away, or maybe more than a year away. There's many challenges that are faced with developing a vaccine. We don't have currently even a vaccine against any of the coronaviruses that are known to man, including the seasonal coronaviruses that we see every year, and then the more deadlier coronaviruses, the ones deadlier than COVID, the SARS and MERS. So it's going to be challenging to develop this. Of course, there's on the bright side, there's a lot of funding going into this across the world. And also on the bright side, there's many, many labs across the world working on this. Developing a vaccine for respiratory viruses is challenging in and of itself. And right now we only have one that we ever use that's consistently used, and that's the influenza vaccine. And even that requires annual vaccination. So there is some signs that we should be optimistic in terms of the funding and the input from all sorts of countries around the world. And hopefully this is on its way within the next maybe year, maybe longer than that.
Wow. Alon, I want to stick with you for a second in terms of the reopening and this delicate balancing act, because I understand, we need to maintain sustained reduction in cases. We need to continue doing that. We need to maintain ample hospital capacity. But then there's the back end of this in terms of measuring how well we're doing as we reopen, which I understand is based on testing and tracing capacity. Can you talk to us about, what are those two aspects?
Yeah, so if you think about in terms of big public health measures that we can use to try to reduce the overall burden of the disease, vaccines, of course, is an important one. And the other important tool that we have is contact tracing, which means as soon as a person is identified, public health contacts them, and then they contact the people that that person came in contact with. And as Beate mentioned, it can become very challenging because you could spread the virus before you even have symptoms. We're not sure to what degree that's pushing the epidemic. But of course, that's going to be a very, very important piece, is identifying everyone that you could have been exposed to try to cut it off. And that means that if the people you're exposed to become symptomatic, we have to be able to test those people as fast as we can. And this is, of course, across the board. It doesn't matter who you are in society, whether you're wealthy, whether you don't have a home, whether you don't have adequate health coverage. Every person in society must have access to the testing in order for us all to benefit, in order for us all to get on top of the problem of the spread of the virus.
So now as we reopen, how do you, as an infection expert, how do you prioritize who should be tested?
So there are bodies in Ontario that are working on this from the infectious disease side to try to prioritize who should be tested. But this was initially a concern earlier on during the epidemic when testing was limited. But now that the capacity has expanded significantly on the public health labs, and then also on some hospitals as well across the province who are now for several weeks and months been able to do the testing themselves, we don't have to prioritize as much as we did before. Now the plan is to think about what other groups do we have to reach more frequently and more consistently. Recently, a few weeks ago, those groups were identified to be long-term care facilities, including patients and staff that work there, rural communities, Indigenous communities, marginalized individuals. Those are the ones that are currently the ones where we're going to have to do a better job of getting tested.
That's right. And Dr. Sander, another measure I understand that I read a lot about in the media in terms of being able to monitor how we're doing as we reopen is this notion of R0 or the R0 factor. Can you explain that to us? Like, what is it and what's it significant as a measuring tool of how we're doing?
Talking about the RS, yeah. So there's a R-North, that's the basic reproduction number. And so what this is telling us is how many people does one infected person infect if everyone is susceptible to that virus. So if nobody is immune in the community. Now that, or some people are immune because they are, at least temporarily immune because they have had the infection. And what we talk about is the effective reproduction number. And this is the one we are watching very, very carefully because that's the one we want to be below 1. So that each person who is infected infects on average less than or fewer than one other person. That's kind of terrible grammar, but yeah.
And this R0 factor or whatever,
Mhm.
was that part of what prompted us to reopen? We see now that it's less than 1.
Yeah, so we keep watching it. It's hard, right? So it's related to modeling, and we don't quite yet have very good surveillance in terms of testing. And maybe I can talk about that a little bit too. And so we do believe that the effective reproduction number or is now below 1 within the general community, not within long-term care or congregated settings. So I really have to say it's kind of 2 different pandemics almost going on. In the community, yes, and so that's where we can think about very, very, very slowly potentially opening. I think I would like to have seen that we have more testing capacity and before we open different businesses again, but so it is what it is. So we are going very slowly.
Yes.
Yeah.
And if this, I guess, delicate balance wasn't enough, my understanding is the wild card in all this still is the virus itself. Like, it seems like we learn something new about symptoms and how it affects us almost weekly. Like I read something this week where there might be a New York and European strain of the virus compared to the Wuhan strain. How challenging is that for you in your jobs? Let's start with you, Dr. Sander.
I'm not sure. There's a lot of new research coming out, but there's also a lot of those things are very uncertain. So not all the science is equally good. So some of the things are new and haven't been confirmed. So we don't really quite know. I think what is important for us right now is what does transmission look like in Ontario and how are we doing? And, so that's, I think, what's really, really important for us.
Dr. Vaisman?
Yeah, it's a good question. Specific to the question of the typing or the mutations happening in the virus, it's unclear yet what effect that has on how things are happening in Ontario. And specifically, does it have any clinical difference for the patients that are affected by the virus? Are they going to be doing worse or doing better with a certain strain of the virus? I think some of that information is going to be valuable in retrospect when we look back and look at what happened in terms of the transmission. And some of that information is going to be hopefully coming out sooner and be able to apply now for the care of patients here in the hospitals. So it's all remains to be seen. And with all the data coming out, it's very hard to sort it out and try to get the truth out of it. Hopefully we'll have better processes as well across the world in terms of sharing of the data and validation of the data so that we can know what's reliable and what's not.
Which must be a very difficult prospect given how fast moving this really is, not just daily, but almost hourly.
Yeah, it's really unprecedented. It's an interesting collision of clinical medicine and epidemiology with social media, with technology, with everything that's been developed on the technology side for the last 10 years. You see it all happening now in real time. And communication has never been better, and data sharing has never been better. So it's a very, from just strictly from the observer point of view, it's very interesting to watch and see how that's happening, how something that's found out in one part of the world is transmitted to another part, and things are applied very quickly. But of course, there's the downsides of the misinformation as well that come with that.
I'm curious where you two sit on the premise that warm weather will help reduce the spread and severity of the virus.
Yeah, it's a very good question that we will actually answer very soon as we, in the Northern Hemisphere at least, warms up. So if we look at other respiratory viruses, certainly we do see a drop in respiratory viruses when April, May, June comes around. Then it picks up again, and starting usually in October when we start to see the virus. If we take that as an analogy, even for some seasonal coronaviruses, then that suggests that things should be better during the summertime. But this is the nature of this virus is very different. For one thing, is that there's no prior immunity. Nobody in a population has ever seen this virus before. So perhaps this seasonality may be seen in the future if the virus persists. But come this summer, we will have some early indication, but it's hard to tell what's going to happen given that nobody's had this.
Dr. Sander, does the warming weather figure into your modeling at all?
Not yet. I think that because there's so many different components, so there's the warmer weather, but I think what's also really interesting is what's going to actually really happen over the next couple of weeks and months, and what we're going to do in terms of opening up, which may be even I don't know if it's going to, more important than the warmer weather, but it remains to be seen what's happening with this.
Another theory that I've read that's out there, Dr. Sander, is that because the virus naturally morphs once it enters each host body, that over time it will morph and become less contagious. Is that part of any scenarios you've run?
It may be. So we do run different scenarios, of course, and it also has to do with the uncertainty in general. So there's still we have learned so much about the virus in this very short time, but it doesn't mean we know everything, right? So there's still a lot of uncertainty, and so we have to try out all those different scenarios. I mean, it's not unusual that viruses change over time. Like we know that that's happening to many viruses. So, and they may become less severe, they may spread even more easily. So it kind of things just change over time. I would expect that. We just don't know how exactly it's going to change.
But no indication to this point that is happening at this point.
Not as far as I know, but I don't know if Alan.
No, not as far as I know either.
Yeah.
Alon, I'm curious, another factor with COVID-19 we keep hearing is that it may not actually be a certainty that all patients who recover from the virus have immunity. What do you make of that?
Yeah, it's a good question. So far, what we know about the virus is that you are immune to it, at least in the earlier part. So, because this virus has only been around since this January or maybe December at the earliest, as far as we know now, the people who have acquired it over the last few months are immune to it and haven't reacquired the virus. But this is so early. This has only been 3-4 months. So what's going to happen in June, July, August? We don't know whether some of those people can get it again. It would be a huge change to what we would be doing in society and doing in medicine if it were in fact true that you were not immune to it in long term. It would have very significant ramifications. If we look at other coronaviruses like this, again, the seasonal coronaviruses, the common colds, people do get those viruses again later on in their life. You do usually, as far as we know, you are immune to it for several months after you've got them, but you can get seasonal viruses again later on. So it may suggest that, it may change the way we do things in terms of vaccination as well, if that ever became available, and also change the way we approach pretty much every aspect of our life if there is no such thing as long-lasting immunity. But we don't know the answer yet, and everyone's like holding their breath and hoping that is the case.
That would be a first in science, I'm guessing.
Yeah.
Sander, when you look to countries that have already gone through gradual reopening, is there anything instructive there? Do we see things that are working there that are useful for us?
It's very, very early. So I do think, what we've seen in some Asian countries, the testing, tracing, isolation very aggressively seems to have worked initially, at least. Other countries are just opening up. So I think it's really too early. I watch very carefully what's going on in Europe with opening schools, at least to some degree, opening small businesses and kind of see what's happening, but all just started. So we need at least 2 weeks for it to see any effect. And then we will know. But yeah, many kind of natural experiments kind of going on around the world, and in Canada as well. Different provinces do different things, just take different approaches. So we watching. Yeah.
I know this is a tough one, but I'm wondering what the two of you think about the potential for another wave or surge in cases, say over the next 12 months. Is that a potential possibility? Is it does it have a higher than usual chance of happening? What's your sense?
I think it's a very, very real possibility, and it comes really down to what we are doing. I think, we were to maintain physical distancing the exact same way we have done it so far. We probably could, theoretically, you could just maintain status quo for a really long time. If that were possible. Like, I'm not saying it's possible because I actually don't think it's possible. I think we need to worry about more than COVID-19. And so how carefully and how slowly we're gonna open is really, really important. And at the same time, rolling out other strategies and hoping for the vaccine. I think the vaccine can come fast enough, but it's probably going to take at least a year. So somehow we need to figure out what to do over that period of time.
Yeah, Alon?
Yeah, I agree that it won't take very much for us to have another wave or even a blip of cases rising. There's always going to be those cases where there is congregate settings or a workplace or a city or a village or region, a province that where measures fall apart for whatever reason, or they're not adhered to precisely, and then you all of a sudden have an outbreak of the virus in that area. And of course, we could, healthcare resources can be mobilized, or public health resources. But because of what we know about the virus so far being so easily spread, and what we needed to do to prevent it, we needed to essentially have a whole societal lockdown for the cases to come down. And it seems that it's likely for this to happen again. Of course, that doesn't mean it has to be very severe if another wave happens. But it seems to be that could very well happen as long as there's no vaccine around to prevent it.
And I think it's totally realistic to expect kind of like an up and down, right? So we open a little bit, cases increase, we kind of sit and see how it's going. Maybe opening up a little bit more, cases are going to increase. So it's kind of going to be this up and down. But I think what we really do not want to see is kind of the big explosion, Italy, New York type scenario.
Yeah, it's right. Like releasing steam out of the Instapot. You want to do that very slowly, very carefully, so that you don't have a sudden urge. Because the name of the game is to protect the acute care sites from being overwhelmed. That's really the most important aspect here. Once that happens, you have increased mortality and morbidity from people who don't have COVID or do have COVID and can't access healthcare. So if you release it slowly and you allow healthcare resources to be adjusted and to be made available, then the population can be protected, and not just acute care, but also the chronic care, anywhere where healthcare is provided.
I just know on the healthcare side, on the front lines, that is like being then in a heightened state of awareness, like every day you go to work, which is very challenging. I'm curious that on the positive side, Alon, for you, in your estimation, what role has physical distancing played in the last 2 months? Has it saved lives in Ontario?
Yeah, I think there's no doubt about that. And as Beate mentioned, there's examples across the world where either things were done late or not done to the fullest extent. And there were situations where the healthcare system was completely overwhelmed. And so the fact that we did things well in Ontario and across Canada earlier on, of course, nothing is perfect, but suggests that we never ended up in that worst case scenario. We never ended up in a scenario where we weren't able to provide ICU beds, ventilators, inpatient beds for people who needed it. As far as we know across Canada, those things were made available. And of course, there is a best case scenario that wasn't met in some regions, but it certainly was not to the worst extent. And the system was not overwhelmed to the degree that we saw in other parts of the world. And that was all because of the social distancing. It was all because these measures were done very early. And also because the population, the Canadians in general, they took it up. They didn't refuse it. They didn't protest against it. And it was very surprising. It was very, I guess not surprising, but it was very nice to see that it was done very well in a very early phase. And people just kind of understood that this is what's required. This is how we help each other. This is how we save each other.
Yeah, well put. Well put. Okay, I've hogged enough time. I want to open up to everyone's questions out there. One theme that actually emerged today, and we want to deal with that first. I think, Alon, we should come to you for this, is a number of concerns from people who are immune compromised and or transplant patients. That's a very special sector. And the overwhelming question from them as we talk about reopening is they want to know, Alon, should they be going out? And if so, what special precautions should they be taking to remain safe if they have appointments or if they want to go to the grocery store, that kind of thing? What would you say to them?
Yeah, I think the patients or anyone in our society who has immune compromise, including our transplant population at UHN, they're going to have to start resuming their normal lives. It's inevitable that they're going to have to continue doing the things they were doing before, but we're just going to have to do it in a more careful way. So we've discussed some of the important things already that they need to continue doing, and things that would be more important for them to do because they have the immune compromised situation. So using hand hygiene, the fabric masks that were recommended by the Canadian medical officer also be reasonable for them to do. Keeping their distance in areas, trying not to use public transportation wherever possible, trying to avoid large crowds, for example, in social gatherings, if we get to that point where we are opening up to that degree. And then specifically at UHN, we've already started recommending that patients who come to UHN are masking. So of course, people are concerned, I don't want to go to a hospital. I don't want to acquire any infections, not just COVID, but other things. But specifically for COVID, one thing that we're doing to protect our patients, including the transplant patients, is that they'll be wearing a mask when they enter the hospital and when they're waiting in the clinics to see their physicians. And we want to enforce that it's important that they do come when they're recommended to do so by their care teams. We don't want people staying at home if they need medical attention. So we want people to feel comfortable coming in, talking to their care teams, and seeking care when they need to.
Well put. All right, now on to all the other questions that have come in on Slido. Thank you again for so many questions. These are terrific. First one, Ontario, Canada has been in a state of lockdown for about 8 weeks. Now, how do you see the next 8 weeks unfolding? Dr. Sander, anything we have to add to that?
I don't have a crystal ball, unfortunately, but so what I do think is going to happen is very much what we observe now already, kind of very, very slow, careful opening. And that can be on the business side. I haven't heard anything about schools yet, so we know they're closed until end of May, but so I would think that's what we're going to see. I also think we will, or I hope we will see clinical service pick up a little bit. Restarting surgeries that had been canceled to some degree, procedures, and taking care of our patients. Yeah.
Alon, I think this next one should go to you. How long can infected breath vapor, the finest particles, stay suspended in a confined space like an elevator or even supported and carried by the wind outdoors? Not everyone wears a mask. And how long can these fine particles rest active on clothing? That's a great question.
Yeah, it's a tough question to answer. We don't know exactly the answer to that in terms of how long it's suspended in air. I think it's important for people to make a distinction between the viruses and infections that are transmitted, what we call through airborne route, which is why you see some people wearing what we call an N95, a respirator, which is a very tight seal around the face, versus those that are transmitted what we call through a droplet route. So if a person coughs or sneezes who has the virus, that virus will not stay in the air very long. It's hard for me to say how long it'll be, but it'll likely be in the range of minutes and not hours. And then gravity will pull it down. And that's because the virus is transmitted through these larger particles where they can't stay for very long in the air. So it's likely in the range of minutes. So if you're in a space next to somebody, if you're able to keep your distance, it's not likely that you'll be contaminated or be affected by them coughing or sneezing. It's even less likely if they're simply breathing or talking. We also don't really know how long the virus lasts on an item, on an inanimate object like clothing, but we suspect it's somewhere in the range of hours. So that just means that we need to be very careful to wash our hands when in public. So if you're about to eat, if you're about to scratch your nose, if you're about to put on a mask, you should be washing your hands. And that will take care of the problem of having anything contaminated on your body, for example, your clothing. It's unlikely that you'll transmit the virus through that way, but we do need to be very careful. We do need to wash our hands, and especially when we're in the public.
A follow-up question for you then, Alon, because I know a lot of people are sensitive to and concerned about using supplies, say masks, for example, that would be well used in hospitals. So people are making homemade, say, cotton masks from materials that they have at home. Are those, in your estimation, those are okay when you go out in public?
Yeah, it's a good question. They're not going to be as effective as the surgical masks or procedure masks you see the staff in the hospital using. But it doesn't mean that they don't provide any benefit. This is actually a very interesting and it's controversial question across the world about whether entire societies, entire groups of people should be wearing a mask. And the evidence doesn't clearly point to one way or another. It's only because this is very early and it's hard to make extrapolations between one society or another. So for example, there's some parts in East Asia, and another good example is Austria, where they're wearing masks more commonly. It's hard for me to say that we should be doing this broadly. But if you do want to use a cloth masks, I don't oppose that. I think that might be a good idea if you feel comfortable doing that. Again, that's also consistent with recommendations from the US and the Canadian federal governments. So as long as it's done safely. What I would say is that you don't need to wear, under any circumstances, an N95 respirator. That really doesn't ever need to be worn in public. That really should be reserved for specific procedures and certain scenarios, only in hospital settings.
Great. This is actually directed to you, Dr. Sander. How has your pandemic modeling research changed since the start of COVID-19? Was there anything that surprised you by the way things have transpired?
That's a really great question. As the way it changed in the beginning, we kind of were mostly interested in looking at very different scenarios of how this pandemic could unfold in Ontario. So kind of, very low rates of infections or kind of really increasing very steeply, and how that would affect our resources in terms of ICU beds and ventilators. So that was kind of the first piece we worked on. Then we looked at PPE, or prisoner protection, and what's the demand for that. We're now looking at essential medications, which may be in short supply. So we're kind of looking at predicting demand, but we're also kind of really moving very heavily into what are good strategies to reopen. And like I said before, it's just very, very challenging because there are so many different ways of going about it. Something that surprised me, I think I was really very, very happily surprised that we did not have the worst case scenario, and that what actually unfolded was pretty much a best case scenario. So I think I'm happily surprised that that happened.
And we all deserve a pat on the back.
I know, we all do.
We've all done our part.
Collectively, pat on the back. Yeah.
Exactly. Yeah, we should be proud of that. Alon, I'll put this to you. What has UHN learned in terms of infection control that will serve to inform post-COVID operations and functioning?
That's a great question. Similar to SARS, one of the most important lessons from SARS came out is the importance of resourcing infection control departments. And since then, many were developed more fully across the province of Ontario. I think that lesson is reinforced now with COVID as well, is that infection control departments across the city, across Canada, have to be very well stocked. They have to be very well resourced with people, with experts, with physicians in order to make things effective. The other important things we learned is that this is also going to be very important in long-term care facilities. So UHN also has long-term care, complex care and rehab sites, but more specifically long-term care sites where elderly patients are living. Infection control there is absolutely vital to try to prevent outbreaks from occurring. And within UHN, other lessons we've learned is the importance of communication between infection control and the other departments, and that has gone on fairly well in the beginning to do so. And it's just about building those and reinforcing it as the pandemic goes on.
That's great. This is next question from Nancy Nielsen. How long do you anticipate Toronto residents will have to wear masks once stores, etc., open again? I think I know the answer to this since we've sort of dealt with this, but I'll put it out to either one of you.
I think Alon answered that already in a way. There's no mask requirement per se right now. I think if you want to wear a mask, it's great, but nobody has to. But generally, I think we'll have to go on until we are in the safe space, which maybe for a really, really long time. I don't know, 6 months, a year, who knows?
And it may be up to each individual workplace, as well as I understand some stores, even retail and grocery stores require it. So you would probably do well to actually check with wherever you're going.
That's very true, and I think we may have. It's not. I would not be surprised if we would have some kind of policy that would require people to mask in general, if they're out in public. Many countries have done that. They didn't have it before, and they have it now as they kind of start opening up. So it may come, yeah.
Yeah. Alon, did you want to add to that?
Only to say that it's important to reinforce that even if you do wear a mask, it's not a replacement for social distancing. So keeping the 6 feet distance is still important. I think sometimes when people talk about whether we should be masking, that's one of the downsides. There's a lot of upsides, there's a lot of downsides. That's one of them, is that people kind of become complacent while they're wearing the mask, not just with the distancing, but also touching their face and things like that. So a mask is no replacement for keeping your distance.
And wash your hands.
This is from Joyce in Unionville. How long would asymptomatic COVID-19 members of the public remain contagious to others? As with some other viruses, could they develop symptoms later? If full-scale testing is not done, I fear that this might be a huge risk to the community at large. Alon?
Yeah, that's an excellent question. There's a lot of pieces in there that we're still trying to figure out, and large-scale testing is part of it to try to help figure that out. We see lots of papers coming out with various numbers of how many people are asymptomatic versus symptomatic. Some papers even say it's as high as 25 to 50%. Some say it's much lower. It's a very hard number to pin down. We hope that we can figure that out very soon because it has very important implications for what we do in public health and infection control. For somebody who's asymptomatic completely without even knowing that they have the infection, it's very hard to pin down how long they're able to shed the virus. I can tell you that if you're about to become symptomatic, so about 2 days before you have symptoms, you can definitely shed the virus. You can definitely spread it to other people, and hence why the contact tracing is so important. So to catch those people who are exposed in that 2 days. But afterwards, it's a very hard question to answer. We suspect that it's somewhere in the range of a week or 2 weeks, but it's hard to get that fine number down as well.
And that's where the back end of this balancing act, where testing was going to be so critical to allowing reopen to continue. Next question. What parameters would need to be in place in terms of infection control measures and disease spread in order for international or even local air travel to be safe? Who wants to take that one?
This is a really, really tough question. We know quite a bit about spread on an airplane and kind of, the way air circulates, and the kind of 2 rows before and behind you are the ones where it's kind of most dangerous. I think for air travel itself, so it's not just the time you spend in the plane. I think it's the time in the airport as well, and like generally being in those crowded places. So we would need to figure out some way of maintaining social distancing in the airport, in the plane, about cleaning it. I don't know if Alon wants to chip in, because this is a really tough question. I don't know if anyone has thought it through to the very end, but it seems like a very challenging thing to do.
Yeah, I agree. It's very challenging. I think Dr. Sander made a great point that when somebody gets on the plane, it's not just the plane you have to think about, it's everything leading up to the plane and after. So going to a hotel, going to an airport, going through security, coming off the plane, going through customs, picking up from the airport, all those aspects have to be looked at. It seems hard to believe that we're going to be able to get back to the volumes of travel anytime soon because all of those elements. None of our spaces, including our airplanes, are designed with social distancing in mind. Except, in fact, airplanes are designed quite the opposite way, to pack as many people in as possible. So there's going to have to be a radical change to how we approach planes. One interesting anecdote is that a paper was released on the very first case of coronavirus that was brought to Canada, an individual who was traveling from Southeast Asia. Interestingly, none of the 300 people on that plane were infected, despite that person being on the plane. That's just one anecdote, but it does beg the question of what do we need to do to try to replicate? How do we prevent that happening on an airplane? There's going to have to be some studies to look at that.
Next, from Pam, can you talk about contact tracing and what Canada is doing about that? Alon, do you want to take that one?
Sure, maybe Dr. Sander also has some ideas, but the basic idea is that I think more and more public health units across the nation are understanding the importance of funding and funding the public health bodies to make them capable of contact tracing. I'm not sure what the current status is across Canada, but certainly in Toronto, they've upgraded as much as they can their staffing to try to do this. So that's obviously, we've talked recently how important that is. Maybe Dr. Sander could speak more to the specific on what's happening.
Yeah, so I don't really know about the specifics. I know people are being trained to do this. So the traditional way really is calling up everyone who has potentially been in contact with that infected person, and that is very, very, very labor intense. So we need a lot of people, like army of people, actually really to do that. There are new methods that are being talked about in terms of using apps to do part of that. And some countries are using that. And I don't think it's replacing actually the public health workers, but maybe a combination of the two could be looked at. So we are not quite there yet, but I know we are massively increasing capacity to do that. So there is contact tracing obviously going on, but to do that on a massive scale, especially if we, as we kind of release our physical distancing, we have to increase that capacity. So we still have work to do.
Yeah. From Peter Mills, the steps taken to reduce infection, social distancing, masks, hand washing, self-isolation, etc., may just take us longer to achieve herd immunity. Is this a gamble that the total infections, or more importantly, deaths, can be somewhat contained until an effective vaccine is available for all? So someone has finally opened up the can of worms on herd immunity. Who wants to take that?
I can take the first step. I think great question. As what you're saying is absolutely right. I think I wouldn't call it a gamble, but I would call it a strategy to try and avoid having many people being infected. I should talk about herd immunity, I guess. So, it's a concept where you think if a large proportion of the population has been infected and is immune or resistant to that particular virus, so they can no longer get infected, then the few that have not had it have a much lower chance of getting it. So it's kind of this idea of why we vaccinate 80-90% of the population against specific diseases, so that the other 10% can also not get it. They're protected through the herd, so there's nobody that can be infected. So having said that, I think there were some discussions around, let's just kind of open the gates and have everyone infected. And as long as 60% are infected, we achieve herd immunity. I personally think that's a really, really terrible idea, just because the number of deaths would be so great, and the human suffering would be just, I don't know, I just can't conceive how that's a good idea. But so everything we do is actually trying to prevent this massive number of cases, to try to prevent seeing all those deaths by buying time, essentially, until a vaccine is available.
Right. Alon, like herd immunity, is that seen as a successful strategy at this point?
Well, I don't think the word is only successful in the sense that it can be achieved, but it's at a very, very great cost of human lives. So it's not a viable strategy, really. The goal of reopening isn't to try to get herd immunity. The goal of reopening is try to safely reestablish some economic activity and social activity of the society. As it's just like opening the Instapot, as I said. Like when you're opening it slightly, you're not trying to get as much of the steam out as you can. You're just trying to get it back to a point where it can be safely done. So trying to get as many people infected as you can is just can be potentially unethical, really, because it'll be at the expense of many more people that needed to die from this who would not otherwise die from it.
I think what we're grasping or coming to terms with right now is the patience that we are going to need to get through this, and the discipline we need to, as you've been saying, wash hands, physical distancing, that kind of thing. It's just going to require a lot of determination on our part. Okay, next question. I understand that it's possible to maintain social distancing in many workplaces once things open up again, but most of us in Toronto need to take the TTC to get to work, which is in normal times extremely crowded at all hours. With more workplaces open, how can people get to work safely? That's a great question. Who wants to take that one?
I think it kind of goes back to trying actually not to open everything at once, but opening things slowly. And in some way, part of the population, I think, like I indicated before, finding some way that not everyone's going to work at the same time and going back at the same time, and kind of have some kind of rotation, and maybe by day, by hour, by some kind of way to, just rotate.
Stagger the workplace.
Population, yeah.
Alon?
Yeah, I agree. It's going to take some very creative thinking, and maybe even a very drastic approach to how we view society, how we view transportation, to get back to anything remotely normal. You can only release so many buses and so many subways to try to reduce the congestion.
Right.
It's going to have to take some very creative thinking from the city planners and the city to have to figure out how that could be done.
All new territory, yeah. From Marianne, newly built hospital in Ontario, an article indicated that the ventilation system was built with SARS and future viruses in mind, preventing air recirculated to other rooms. Does this indicate recirculated air can carry the virus? And if so, are UHN hospitals safe when it comes to air recirculation?
Yeah, it's a great question. We did hear of some rare case reports related to SARS of virus being transported through ventilation, but it wasn't, as far as we know, the virus is not airborne, so it's not an effective means of transporting the virus. And many of the cases that we've seen, say in workplaces or in restaurants where we've seen COVID being spread, it's presumed, again, not to be due to the ventilation or circulation. It's due to direct droplet contact. So somebody sneezes or coughs, or some material is infected and another individual touches it and gets infected. So it's an excellent question about the ventilation, something that we should always be, of course, be aware of. At this moment, it's not suspected to be the problem, but we're always keeping an eye on these things to make sure that it's not spread that way. I think if it was spread through ventilation, we would see a lot of outbreaks across the world in many hospitals. Of course, many hospitals even older than UHN, we would see a lot of problems, and we're not seeing that currently. And it's true that some recirculated air is used in a hospital, just like in any building, but that air is filtered. So we do bring air from outside the building as much as we can, and then otherwise we try to use air that's filtered. It's not returned back to another room after not having been cleaned.
Yeah, HEPA filters, right?
Yes.
Okay. Next question. Will your lungs ever recover and get back to normal after COVID-19? Is there anything special that recovering patients should do or not do?
Yeah, similar to other respiratory viruses or other bacterial infections of the lung, there's always a possibility that you have irreversible lung damage as a result. It's not common with other viruses. It's not common with other bacteria. But as a matter of having been severely ill, it's possible that you have some lung function problems after you have a very, very severe infection. So it's a very good question about what they should specifically be doing. That I think that'll be better answered by a respirologist or a lung specialist. And if those individuals do require hospitalization, they do have a severe viral infection, they will be referred to a specialist after they leave hospital to make sure that they're well looked after. So just to want to reassure the audience is that if that ever happens to anyone, at UHN, we have the resources to provide help for those patients.
All right. Can the virus enter through a cut in the skin or be sexually transmitted, or is it uniquely a respiratory infection? And how do you account for it entering through the eyes? I've always wondered about that myself. What do you think, Alon?
Yeah, it's a good question. As far as we know, COVID is not a blood-borne infection, nor is it sexually transmitted. So the way you pick up the virus is by having it come in contact with your mucous membranes, usually the nose or the throat or the mouth. I suppose it's also possible to come through the eyes to make contact with the mucous membranes of your eyes. That would just be not a common way for it to infect you. It just simply be more common for it to be going through your airway, because that's where the virus attacks. That's the cell types in your lungs or the lining of your airway is where the virus can actually attack and cause problems. Although sexually transmission, I suppose it's possible. It hasn't been established, of course, by virtue of being close to, more likely to pick up the virus that way. That's far more likely to be the mode of transmission than, say, through like direct sexual intercourse, for example. But no, through the skin, it hasn't been identified as a source of infection directly through the skin into the blood, unlike other viral infections.
Great. Next question. What is the risk estimated to be for dentists, dental assistants, hygienists, and dental staff that work by producing aerosols? Oh, yeah. Is it believed that these aerosols could also travel through ventilation, then infecting an entire dental clinic? Alon, I'm gonna guess you're gonna take that.
Sure. Yeah. So the ventilation question, I think we had talked about a few minutes ago.
Sure.
Regarding the dentists, so certainly there are some dental procedures which can lead to what we call aerosolization of the particles or the virus. So I mentioned earlier the large droplets, which are pulled down by gravity. Aerosols, colloquially, we refer to those as being very tiny droplets, less than 5 micrometers or so. And they can potentially go in the air and be suspended there for longer. So in that case, if you are generating aerosols, those certainly can be sitting in the air for far longer because they just suspended there. So during higher risk procedures where the aerosols are being generated, and some dentistry procedures would be included in there, then special precautions would be taken, including performing the procedure in what we call a negative pressure room. where the pressure allows things to be sucked into the room instead of pushed down into the hallway. And then wearing the N95 that I mentioned earlier, a tightly fitted respirator, and that is able to filter out airborne particles. So that, again, this is regarding patients who have the virus. This is the precautions you would take if they absolutely needed to have a dental procedure performed. But generally speaking, we would recommend that dental procedures are delayed for people who have the virus to reduce the exposure to the healthcare workers, including dentists and their assistants.
Right. Yep. Hi, what is the latest research assumptions about virus effect on small children 1 to 3 years old? Parents are struggling, working from home and watching children, not to mention other obligations, but daycares now seem dangerous. Is it prudent to reopen them in the next few weeks? Thank you. Who wants to take that? Alon?
Maybe, yeah, Dr. Sander, if you want to go ahead.
Go ahead.
Initially, we believe that children are very unlikely to acquire the virus or to have bad outcomes. We now know that it's possible for children to have serious illness related to the virus. It's still true that it is far less likely to occur a bad outcome than in an elderly patient. So children can probably carry the virus. We're just trying to understand about how common that is and whether they're able to transmit to the adults as effectively as, say, other viruses or other bacteria that we know often circulate among children. Anyone who has children, of course, knows that they often have runny noses, and often that's because they're carrying viruses through the winter season very easily, and they transmit it to their parents, to their grandparents. So that part is still being worked out. As for the daycare piece, that's going to be very challenging. Maybe Dr. Sander, you want to address?
Yeah, I think I totally agree. I mean, we know children can transmit. We know they can get sick. They're not as likely as adults, but still, I don't see daycares fully opening within the next week or 2 or maybe 3. I think what I would hope for again is that maybe daycares open on a rotating basis. So at least, I think as a parent, I was saying, well, if your kid can go at least to daycare Monday and Wednesday, and that, so you can plan for that, right? So you got 2 days a week where you can focus on your work or other things and not on 10 million different things. And then maybe the other kids go Tuesday and Thursday. So some kind of rotating basis, or only mornings, only afternoons, this type of thing. But a whole daycare opening, I think, will be very tough, especially with the little ones who I would say it's so difficult to even just think about social distancing or physical distancing. That's really tough. Hand washing is tough. Also, they can do it. Masking would probably be really, really difficult. I think it's much easier to think about it in terms of schools, or maybe a grade 5, grade 6 kid who can wash their hands, physical distance, and wear a mask if they wanted to. So yeah, it's a really, really tough question. I don't think it's going to be everyone, but some kind of rotating basis, hopefully. And that will be helpful, I would think.
Right. Yeah. We have, I think, time for one more question. This one is from Fred Weber. Canadian researchers are cooperating with those in other countries, trying to find treatments and vaccines. Will Canadians have equal access to those solutions, even if approval for use is first achieved in another country? Will we get manufacturing licenses so that we can produce our own supplies? Great question, which I know has created some controversy over the last few weeks. Who wants to tackle that one?
Dr. Sander? It's Canada, of course, isn't as big a market as the United States is. So what we found generally in the past is that for example, for antibiotics, the market is much bigger in the United States, and they often get licensed there before. And sometimes we don't even get access here because it's not worth the time of the company to market it here. But I think that there's a different story when it comes to COVID in terms of the public outcry or the public demand for treatments to be available in Canada. And there is of course, a lot of lobbying power behind the Canadian government to try to get this done in Canada. I don't think people would find it acceptable that there is an effective treatment outside of Canada and it would not be available here. So unlike other, perhaps less common illnesses where there isn't as much demand to try to make certain drugs available here, this would be a totally different story, and there'd be a lot of political pressure to make that happen. Of course, Canada is one of the wealthiest countries in the world, so there'd be probably more of a need for that, more of a pressure for that to be available here.
Yeah, on behalf, we do have manufacturing capacity, so we could do it. So it's really around the licensing. Just maybe thinking back on influenza pandemics, where we do stockpile and where we have agreements in place so that we do get vaccines. And so kind of that's all set up prior to a potential pandemic. So this is a different situation, but I would think that we are working really, really hard, that our government working really hard and securing those licenses and being able to produce it in Canada.
We have come to the end of our time. To all of you at home, thank you for taking the time to join us. And I really want to thank our two guests for taking time out of their busy days to talk with us. Dr. Alon Vaisman, infection control physician at UHN. Thank you.
Thank you.
And Dr. Beate Sander, Director of Population Health Economics Research at the Toronto General Hospital Research Institute. Thank you, Dr. Sander.
Thanks so much. It was great to be here.
This live stream, as always, they'll be up on the Foundation YouTube page shortly. And for anyone interested in donating supplies or support items for our frontline workers, you can email COVID support, that's all one word, COVID support @uhn.ca, and someone at the Foundation will be glad to help you out. And as always, all donor support is critical to the work that's being done at UHN, both on the front lines and in terms of the research behind the scenes, people racing to find treatments for this deadly virus. So if you're able to help, we ask you to consider making a donation to www.tgwhf, that's tgwhf.ca/help now. Thanks for tuning in, everyone. Keep practicing physical distancing and stay safe.